Okay, this is Emergency, Violence, and Abuse, Nursing 203, Module E Selected Emergencies. The lecture does have parts of it that come from your Med-Surg nursing book, your psychiatric mental health nursing, and your pharmacological aspects for nursing care. A lot of it, though, is going to come from just your Integrity lecture. As a reminder, this does come from your pharmacological book, and it is page 13. Schedule 1, Schedule 2, Schedule 3, Schedule 4, and Schedule 5 drugs. We're just going to hit the high points on these, just as a reminder again from Nursing 104. All of your Schedule 1 drugs have a high potential for abuse. The drug or other substances have no currently accepted medical use in treatment in the United States. No prescriptions can be written for Schedule 1 substances. Schedule 2 also has a high potential for abuse. The drugs or substances do currently have accepted medical uses for treatment in the United States, or a currently accepted medical use with severe restrictions. The abuse of Schedule 2 drugs or other substances in Schedule 2 may lead to severe psychological or physical dependence. Schedule 3 drugs. The potential for abuse in Schedule 3 is less than the drugs in Schedules 1 and 2. Schedule 3 drugs do currently have accepted medical usage in the treatments in the United States. Abuse may lead to moderate or low physical dependence or a high psychological dependence. Schedule 4 drugs have a low potential for abuse relative to the drugs in Schedule 3, 2, and 1. Schedule 4 drugs do have current accepted medical uses in the treatments in the United States. The abuse of Schedule 4 drugs may also lead to limited physical dependence or psychological dependence relative to the drugs that are in Schedule 3. Control measures for Schedule 4 are similar to the control measures for Schedule 3 drugs. Prescriptions for Schedule 4 drugs may be refilled up to 5 times within a 6-month period. Schedule 5 drugs have the lowest potential for abuse relative to the other scheduled drugs. Schedule 5 drugs do currently have acceptable medical use in treatments in the United States. The abuse of Schedule 5 drugs may lead to limited physical dependence or psychological dependence relative to the drugs in Schedule 4. This category consists of preparations containing limited quantities of certain narcotic drugs, generally used for antitussives and antidiarrheal properties. Some states, the example of this would be North Carolina, have initiated a new schedule, which is a Schedule 6 drugs. The only drug in the category of Schedule 6 drugs is marijuana. The reason for this is that marijuana has a limited medicinal use by prescription in selected situations. And as a note on your slide at the bottom, it does state that any and all medications have the potential to be abused. This is just a review of definitions. Addiction is a disease caused by changes in the brain that affect human behavior and is seen in the individual by the overwhelming craving of the substance, the seeking out of the substance, and by this scenario just beginning to be repeated over and over and over. The craving, and then the seeking, and the craving, and then the seeking of the drug. Withdrawal syndrome has significant possible manifestations associated with it. Some are difficult to treat, such as hallucinations, severe irritability and aggression, restlessness and hyperactivity. When a patient is addicted, their health risks automatically increase and are made life-threatening in some clients, especially if they already had an impaired health status. For example, the example the book gives is an increased risk of cardiovascular health problems with the addiction to certain substances. But now, if the client already had an underlying cardiovascular disorder, such as an uncontrolled hypertension, then the risk does become life-threatening. It is not uncommon that the spread of HIV and AIDS, as well as STDs, are linked to substance use. misuse, and abuse. While yes, alcohol is a legal, mind-altering substance with no medical usage, it is sometimes compared to cocaine usage. With a drastic increase in the abuse of alcohol yearly, alcohol with both legal and non-legal mood-altering drugs, both prescription and non-prescription. With this taken into account, the production of these substances are being reduced in an attempt to reduce the abuse of the drugs. The fallout of this is that the cost of abuse to society is great. The drugs become more expensive and in less demand. And the only persons that it seems to be causing difficulty to in obtaining these drugs are the people who are trying to do it legally for prescription use. Frequently, triggered stress responses cause cortisol release in the body. This can result in a more sensitive response to the drugs. So continued abuse of the substance creates a cycle of needing more and more amount of the substance to maintain the same desired response as before. And when the body is deprived of the drug, or even deprived of the amount needed of the drug, the body responds in a withdrawal symptom. Some studies will say that there's a genetic link that is associated with drug abuse. Other studies say that there is a relationship between antisocial personality disorders and drug use. One study revealed a difference in the genes of someone who abuses illegal substances, such as cocaine, with the genes of someone who abuses legal substances, such as alcohol and nicotine. The use of internet to buy medical products is growing rapidly. Many consumers benefit from the convenience and the privacy of this new option. Unfortunately, both consumers and legitimate pharmacies are now being threatened by rogue sites. These rogue sites have fraudulent and disreputable businesses that sell these products illegally. There are many medications that are available in the United States, but only under specially created safety controls. If these drugs are bought over the internet or bought from foreign sources, then the safety controls are bypassed, which places the patient or the user at a higher risk. In addition, the drugs that are bought from foreign sources are generally not FDA approved. So therefore, you can never know exactly what the purity or the substance in each drug is with certainty. The website listed on the slide is a website address that gives you a listing of warnings, tips, and alerts if you're going to be making any online purchases for medical products. Drug Abuse Warning Network. This is called DAWN. Now, DAWN is a public health surveillance system that monitors all drug-related emergency department visits within the United States. It reports all types of drugs being illegal, prescription, over-the-counter pharmaceuticals. Some examples of over-the-counter pharmaceuticals that it monitors would be like dietary supplements and cough medicine. It also monitors the substances inhaled for their psychoactive effects. Alcohol is considered an illegal drug when it is consumed by patients age 20 or younger in the state of Alabama. Since 21 is our legal drinking age, for patients age 21 and older, alcohol is only going to be reported when it is used in conjunction with other drugs. Some findings of the report from DAWN were that an increase in the number of drug-related emergency department visits did involve illegal drugs in the short term between 2009 and 2011. It also revealed that short-term increases were present in the involvement of both illegal and legal stimulant drugs. Some of the indications from the Dawn report were that the pace of increase in pharmaceutical involvement was beginning to slow down some, though. You can read the 4 bullets listed on your slide. Some interesting facts in our emergency department drug-related visits are that the average age of those who visited the emergency department with a drug-related issue was 42 years old. The distribution between men and women were about equal. There was no gender specifics. The average length of hospital stay from complications that were a result of the drug use was about 6 days. And the average cost from this emergency department visit related to drug use was $8,900. So you can see what an expensive issue this is for society when so many of your drug-related patrons to the emergency room do not have insurance to pay for this treatment. In addition to those listed here on the slide, you must remember to include alcohol and nicotine in the categories of substances commonly abused. In your Med-Surg book, on page 244, table 16-4, there's a list of herbs with potential effects on the body. Do not discount the use of your general nutrition supplements just because they are not requiring a prescription does not mean that they are not drugs that once ingested do alter the body's chemical makeup or mental status. Stimulants tend to be abused for a faster, better feeling, a longer lasting effectiveness. Hallucinogens are commonly abused as mind-altering medications, and depressants are commonly used in addition to anti-anxiety medications. They seem to be society's way to respond to the ever-increasing demands of today's busy life. Opioids are commonly used and abused. They may start out being prescribed for such as treatments to therapeutic pain relief, and once the drug is used in a way that it was not prescribed, it becomes an abused drug. Stimulant, hallucinogen, and unspecified narcotics make up about 44% of your emergency department visits. Depressants, inhalants, and anabolic steroids make up about 56% of all emergency department visits. In 2004, 8.2% of all visits involving drug misuse or abuse were related to methamphetamine use. However, by the year 2008, that percentage had dropped to 3.3%. More than 1/4 of methamphetamine-related emergency department visits during 2008 also involved combining the methamphetamine with either one drug or combining with 2 or more drugs. Of the visits that were methamphetamine and an additional drug, 25% of those were alcohol, and 22% of those were marijuana. Methamphetamine use has been in the public eye since the late 1990s, when the use of this drug, which began as a West Coast phenomenon, quickly began moving eastward and increasing. The trend began to taper off a little bit in the statistics of 2006. According to a national survey on drug use and health, the number of people using methamphetamine in the past year fluctuated from 1.6 to 1.9 million persons between 2002 and 2006. And then it decreased in 2008. The recent decline in treatment admissions for methamphetamine use may be attributed to a variety of supply and demand reduction efforts. In 2005, the federal government enacted the Combat Methamphetamine Epidemic Act of 2005. What this act did was limit the amount of pseudoephedrine and ephedrine that could be sold over the counter, and it required secure storage of these drugs within the pharmacies. Now, in response to this serious public health concern regarding methamphetamine use, several local prevention efforts were also launched, which culminated in a federal initiative through the Office of National Drug Control Policy. It provided communities with methamphetamine prevention tools, treatment providers, research. All of this demonstrated the strong addictive properties that methamphetamine has. Once, methamphetamine was thought to be untreatable, but now with the research and the different resources put in place, we are finding that methamphetamine addiction can be effectively addressed. Substance abuse occurs when these criteria are met. Losing control over the use of the drug, ingesting a drug that has already proven to the patient that it is causing adverse conditions in their own body, demonstrating cognitive, behavioral, and physiological disturbances whenever they use the drug. When admitting a patient to the hospital, you have to ask information on alcohol use, tobacco use, prescription and over-the-counter, as well as herbal and illegal drug use. Each can cause an interaction within the body or be symptomatic or cause withdrawal. If the patient has been receiving long-term treatment for chronic pain with opioid therapies, you as a clinician have to know that it is more difficult to effectively manage this person's pain in the hospital. If the physician is not ordering the dosage that the patient is used to taking at home, it's going to cause the patient to experience withdrawal symptoms, and their pain is not going to be relieved. The patient then begins to feel very powerless, angry, hostile, and desperate. Try, as your patient advocate, to remain objective. Don't label the patient. Advocate for proper pain control. Assess the patient's vital signs frequently as your guide. Also assess the impact of pain on the patient's ability to function, such as their ADLs. It is your responsibility to discuss with the patient the risks involved and how chemicals affect their body therapeutically, as well as the life-threatening risks of overuse. Discuss with them their length of stay, the course of treatment, and recovery times, all of which may be very altered in a patient that has a substance abuse problem. Part of your treatment and planning for this patient is going to be determining where their needs will be safely met after they are discharged. Does this patient desire treatment for substance abuse? This is your first and foremost question. If no treatment is desired, then you're limited to educating the patient and discharging them home, as they may try to choose to independently handle their abuse problem, or they may choose to continue the abuse of the drug. Do not overlook this in the geriatric population as well. Your geriatric patients are substance abusers in some cases, especially in the case of polypharmacy, alcohol use. Also, your geriatric patients have difficulty metabolizing and excreting. This only increases their risk of toxicity. Some of your older patients have difficulty with impaired memory. This can lead to overuse of or underuse of medications that are prescribed. When a non-therapeutic drug is suspected to be used in a way that it was not prescribed, you need to communicate with the prescribing physician to correlate blood and or urine test to determine any types of substance that might be present in the body, so that you can clarify what you're dealing with. Your best safeguard for the nurse and substance abuse is to have policies and procedures in place that are going to strictly account for drugs with abuse potential to discourage drug misuse. Witnessing drug wasting, opening packages at the bedside, clear and accurate documentation. Practice nursing as a nurse that demonstrates responsible and accountable professional behavior when you administer meds. It's also your duty to report any colleague to the appropriate administration if you suspect substance abuse or use is going on. It is your duty to maintain public safety, and that is your primary responsibility as a nurse. State boards of nursing have peer assisting programs to aid in identifying and managing nurses with substance abuse issues. The National Organization of Alternative Programs also assists healthcare workers with substance abuse, and I've given you that website. Your impaired healthcare providers. It is estimated that approximately 10 to 15% of all healthcare professionals will misuse drugs or alcohol at some time during their career. Although the rates of substance abuse and dependence are similar to those of the general population, the prevalence is disturbing because healthcare professionals are the caregivers responsible for the general health and well-being of the population. Healthcare professionals have higher rates of abuse with benzodiazepines and opiates. Specialty areas such as anesthesia, emergency, and psychiatry have higher rates for drug abuse. This statistic is related to the high-risk environment associated with these specialty areas. In addition to the baseline personalities of these healthcare providers and the easy access to the drugs in these areas. Nurses and attending physicians use drugs of abuse to enhance performance and as self-treatment. The self-treatment may be for various different reasons such as pain, anxiety, or depression. Your institutional, local, and statewide impaired physician programs are available for the active treatment and rehabilitation of impaired healthcare professionals. Now, many of these programs are also designed to assist the healthcare provider with re-entry into the clinical practice. It is rarely used as punitive action, and punitive action is rarely taken when a healthcare professional undergoes successful treatment and ongoing follow-up management. Returning to the workforce following treatment for substance abuse also has extreme challenges, but your healthcare professional can return to their career. Overall recovery rates for an impaired healthcare professional seems to be a bit higher when compared with other groups, particularly when it is done with an intensive inpatient management and subsequent follow-up care. Alcohol. Increasing binge drinking for young adults and college students and universities result in emergency department visits and complications and deaths each year. Approximately 1/2 of those cases involve alcohol consumption by the perpetrator, the victim, or both. Alcohol was involved in 42% of Alabama highway deaths in 2005. The maximum blood alcohol level under Alabama state law is 0.08 grams per deciliter. The average blood alcohol level of the drunken drivers in 2005 was 1.4 to 1.5 blood alcohol level. And this is going to be your most objective assessment. An at-risk drinker is described as someone who drinks 5 or more. This is male. A male that drinks 5 or more, or a female who drinks 4 or more 12-ounce beers or 5-ounce glasses of wine. Alcoholism is alcohol dependence. This is a disease. It does cause cravings and compulsions to consume alcohol. There is an inability to limit consumption once they begin. Without the alcohol, they do experience withdrawal symptoms such as nausea and vomiting, sweating, tremors, disorientation, and it does require increased amounts because of the tolerance level built up. Withdrawal symptoms cause the brain to become hyperexcited because the alcohol depresses the central nervous system. So when they have alcohol on board, it causes relaxation, causes them to be calm, euphoric, loss of inhibitions, and sedation. So the opposite effect of that is what the patient experiences in the withdrawal. So if alcohol relieves the withdrawal symptoms that your patient is experiencing, they do have a true physical dependency and they are experiencing alcoholism. With alcohol abuse, there's no real craving and no loss of control. There's no physical dependence, but this individual has problems that do result from the alcohol consumption, meaning that they have failures at home, work, or school. They drink in unsafe situations, and then they continue to drink when it causes them the problems that they're experiencing. When one or more of these drinking episodes occur within a 12-month period, they are considered to be abusing alcohol. Again, treatment is always going to depend on the patient's willingness. Signs and symptoms of alcohol withdrawal. You have your mild symptoms 6 to 24 hours after the last drink. And the severe symptoms begin 24 to 72 hours after the last drink. And then your severe symptoms are going to be in addition to the ones you see as mild symptoms. A condition called delirium tremens, or DTs, usually is considered a severe symptom beginning 24 to 72 hours post-drink. Someone experiencing alcohol withdrawal can experience these symptoms for up to a week, in addition to having auditory and visual hallucinations, experiencing tachycardia more than 100 beats per minute, and hypertension with a diastolic reading of more than 100 millimeters mercury. The most threatening result of alcohol abuse or alcoholism is the withdrawal from the substance. These mild symptoms progressing into severe symptoms, delirium tremens, hallucinations, and can progress on into death without treatment. The life-threatening stage of alcohol withdrawal requires emergency medical interventions. It may be accomplished I said it may be accomplished, but I meant to say it may be accompanied by alcohol-induced seizures. These alcohol-induced seizures may be starting in 12 to 48 hours after the last drink. The priority intervention is safety from self-harm, harm to others, reorientation frequently, administer any prescribed medications to calm the patient. Usually it's benzodiazepines such as Librium, or Valium may be given to prevent the seizures and the delirium tremens. Beta blockers may be given to reduce cravings, decrease pulse or blood pressure. Your patient may need an increased protein or caloric intake. Also education on rehab or support within their community, such as Alcoholics Anonymous or AA. Possible aversion therapy, and the patient may also be prescribed anti-abuse if it is a patient that truly wants to stop drinking and has that strong desire. Drug and alcohol intoxication does markedly disrupt brain function. You can see the 3 brain scans of the sober individual on the top, and you can see how much activity with the red and the yellow. This is activity within the brain. And then the 3 brain scans on the bottom are your intoxicated individual, and they are intoxicated at 0.1. And you can see there's hardly any yellow and no red or orange. So it does disrupt brain function.